All right, and we're back to another episode of the NICU Doc Answers. Now, I was asked about whether babies actually have or feel pain and what should we do about that. Do we have anything for pain and sedation? So, let's get to it. First thing first, yes, I believe, strongly 100% believe babies feel pain. Giving the trainees all those NICU secrets, teaching the families, bringing you physiology and the latest evidence and management of NICU babies. Just having fun with it. Believe it or not, it wasn't that long ago that we actually thought babies felt no pain. Yikes, I know, it's crazy to think there was a time where we felt that babies felt no pain. And in fact, there were procedures that were done, maybe even surgeries. I'd hate to believe that, but I've heard stories. Maybe even surgeries done on babies where there was no anesthesia used. God forbid that's true. But anyway, we, thank God, no longer are doing that. Well, of course, we now know and strongly believe, at least personally, that babies do feel pain, okay? Most people obviously know that. The question, to what degree, and what we have to be very careful with is balancing out how much sedation and how much pain control do we give. Why? Because obviously what we have to deal with when we give pain and sedation is that we have to deal with the side effects. So let's get to the actual pain part first, and then we'll talk about the medications in itself. So how do we know that babies actually feel pain? Well, visually, when you are causing or doing something that could be causing pain to a baby, you do see facial expressions, you see body changes in the way they behave, and these have actually now been put into pain scales. And so there are different pain scales that have been used, and it also does depend on whether they are premature or full term. And some of these different pain scales are validated, some are not. So let's name some of the different pain scales, okay? And again, some of them are validated, some of them are not. So we have the Neonatal Infant Pain Scale, or the NIPS. We have the Neonatal Facial Coding System, or the NFCS. We also have the Neonatal Pain, Agitation, and Sedation Scale, which is the NPAS. This is commonly used. We also have the CRY, Required Oxygen, Increased Vital Sign, Expression, and Sleepiness Scale, or CRYS. Now we also have the Comfort Scale, and there is something called the Dolorige Nouveau-Né, or DAN scoring system. Obviously this is French, I'm not familiar with it, and I'm probably butchering the name. I am sorry for those that speak French. I speak a little bit, not enough to pronounce that very well. I apologize. So there is also, those are for full term and infants. There is also the Premature Infant Pain Profile, or PIP, and this is a validated pain scoring system for premature infants. In the description, I will put the names of these different scales. I will also put the source of where I obtained these pain scales, so you can read about the scoring system and also in general about pain in newborns, okay? So I'll put the source of where I'm obtaining this, okay? You also have for older infants and non-verbal infants, so for example, if you have a cognitive impairment in older children, you can also use the FLAC scale or the revised FLAC scale, and that is the face, legs, activity, crying, and consolability scale, okay? The FLAC scale. So again, I will mention that, and I'm also gonna put the chart up here for you guys to see the different scales, okay? So those are different scales that we use commonly in the hospitals to try and determine the different scores, okay? And especially we use sometimes this on a daily basis. We use this also if an infant or a baby has gone through surgery. And so we have a better idea of what pain they're going through, and that way we can respond to that. Now, let's talk about how we respond to that, what medications we can use for pain and also sedation. Let's be clear, pain and sedation are different things. When you are in pain, you deal with certain receptors that actually have to do with pain. So you can be in pain, but when you're talking about sedation, sedation has to do with an area of the brain that basically dumbs things down. Pain has to do with an ouch. Those receptors really have to do with the idea that it's sending that signal to your brain that there is something bad that's going on with cells, with tissue, that there is imminent damage happening to an area. But that doesn't necessarily mean that there is, again, sedation, that there is a dumbing down effect. So these are completely different effects that are happening at the central part, at the area of your brain, okay? So these have to do with two different medications. So for pain, from the simplest thing that we use in the intensive care unit in the NICU, pain, we can use something like Tylenol, okay? So Tylenol or acetaminophen or paracetamol that's used in Europe and in other countries around the world is basically a medication that is very simple, and it's broken down in the liver and it does not affect the kidney. Why is this important? In babies less than 6 months of age, you cannot use something like an NSAID, a non-steroidal anti-inflammatory. Why? An NSAID is a medication that actually goes and is basically taken up and can actually affect the kidney in infants less than 6 months of age. Why is 6 months really important? The flow that happens in the kidneys in babies less than 6 months of age is actually not very good. The blood flow and the urine flow that happens through the kidney is actually pretty poor. What happens is that this non-steroidal can actually build up, this NSAID I should say, and keep in mind when I say non-steroidal, I know people freak out with the word steroidal. This is not a steroid, okay? Keep in mind, non-steroidal, okay? This is an inflammatory medication. It helps with inflammation. It is not a steroid, non-steroidal, NSAID, okay? But it can build up and actually cause damage, something called acute kidney injury or AKI. It can actually cause damage to the kidney. Now, in older babies and us, and if you don't have kidney damage, if you don't have an underlying kidney problem, it's not that big of a deal as long as you follow the recommendations of the doctor of how to take it, and obviously of how to take it on the bottle, right? Because you have pretty good kidney flow, blood flow and kidney flow, you're able to get rid of that medication. However, babies less than 6 months of age, that can build up and it can actually cause damage to the cells. If it continues to cause damage, it can actually cause end-stage renal problems. It can actually cause, you can basically kill that kidney. So you have to be very careful in babies less than 6 months of age, and therefore we do not use it. There is a particular non-steroidal NSAID that we do use for a particular, for a couple of situations, and those are for closing a PDA. We do use ibuprofen, and we use actually indomethacin for closure of a PDA, and also sometimes to help with the neurodevelopment. That is another video. Maybe I'll do that, but that's a different situation. We won't get into that right now. Okay, so Tylenol. It's actually pretty good, and we actually, for certain situations, if you have a minor surgery, you can actually use standing Tylenol. It covers enough for small wounds, small puncture wounds, if you're doing something like a G-tubes or small holes where you're not really opening a lot of fascia, you're not opening a lot of areas, there's not huge open wounds and open cuts. For small wounds, you can actually use Tylenol, And what you would do on top of that, which is the next medication we're going to talk about, is morphine. So you use an opioid on top of that to basically overcome just if there's any peaking pain on top of that, okay? But it's a good medication. The babies are able to clear that through the liver very well, pass through the kidney, any toxicities, any metabolites that come from that. So Tylenol is a great medication to use. You can use it standing, meaning every 6 hours, 4 to 6 hours to get rid of that. Really, you can use that for 24, 48 hours. That is usually good enough, again, for minor surgeries or any type of pain, wounds that are not, big, okay? Next step I already talked about. You can go ahead and move now to a minor narcotic or a opioid, such as if you want to use morphine or fentanyl. These are two narcotics. Okay, what is the difference between morphine and fentanyl? They do act on very similar receptors. The difference really is how quickly they act and their half-life. So very briefly, I'm going to talk about half-life and what that is. The half-life of any medication, so this is not unique to these narcotics, the half-life is essentially how long does it last within the body, how quickly does it get eliminated. The fentanyl is very quick to get into the body. That's a great medication if you're going to be doing a procedure that's very quick and you need to go ahead and get a medication in fast into to get relief for the baby. Fentanyl is very good, very quick acting, and it has a very short half-life, meaning really once you get it in, it can get out of the system very quickly. And this is really good because the thing with narcotics, one of the problems with using narcotics is that it can actually cause respiratory depression. It can cause babies to stop breathing or at least slow down their breathing. And so what you don't want to do is a baby who's not intubated, who doesn't have a breathing tube, and you're protecting or breathing for them, what you don't want to do is cause them to suddenly stop breathing. And then you have a problem now because you may be doing a procedure, you may be at least helping them. They may have come back from the OR, they're getting something done, now they stop breathing. So that's a big deal. So you may want to use something like fentanyl, help their pain, but then it gets out of the system and then you're done. So that's why we would use something like fentanyl. Now when you're using something like morphine, it does take longer to act, but it does stay longer in the system. So some people prefer something like that because obviously if you have had a procedure that's more invasive, if you've had a wound or a surgery that required longer time, or if you've had to go through lots of tissue, if you have a big wound that obviously cause a lot of trauma, then morphine may be a medication you'd rather use because obviously this is going to be taking more healing time. So you want to be using something that has a longer half-life, and therefore morphine might be more adequate than fentanyl. However, you can use both of these if you're using a drip. So if you're going to be using a constant infusion of this, then both of them are adequate to use. Once you turn it off, fentanyl will get out of the system faster, morphine will take longer. And so those are something to consider when you're thinking about taking off a drip. So that's pretty much it as far as using narcotics. So now let's talk about sedation. As I mentioned before, sedation does not act on pain receptors. So you are dumbing down the brain, but you're not really calming down, you're not really acting on the pain receptors. Now, you may be up to a point, you may be using the sedation to a certain dose where your brain is so dumbed down that it may be dumbing down all the receptors, including your pain receptors. Those doses are usually when you're reaching really high doses. And sometimes we do use in the intensive care unit very high doses of everything. But you shouldn't, when you're getting to that point, you shouldn't just be on sedation at very high doses. At that point, you're usually using also different opioid, using, sedation and opioid combinations. You shouldn't just be on sedation at very high doses. Okay, so let's talk about the two medications that we use commonly in the NICU, and these are in the same family, and that is basically midazolam and lorazepam, or commonly brand names that we use here in the US are Versed and Ativan. So these two are similar to what we talked about with fentanyl and morphine. They have to do really with their half-life. So midazolam and lorazepam, midazolam is much faster acting really when compared to lorazepam. Lorazepam is a little bit slower acting, but it also has a longer half-life, so it sticks around a little bit longer. So lorazepam tends to be used more for patients that may have maybe needing for sedation purposes to sort of come down on a longer term. Versed, you probably use it sort of short term, or if you are going to be doing again a procedure, or if you're going to be using a drip. Versed, or again midazolam, tends to be favored over use in Ativan. Ativan tends to be more of a PO type medication for a patient that you want a sort of a longer term sedation. So otherwise Versed, again, shorter term, that tends to be the favored medication. So that's how we choose one or the other. If you're using a drip, Versed, midazolam, that's the go-to drug over using Ativan or lorazepam. Okay, so let's talk about a medication that I've seen more recently come into the NICU. It's been used in a lot of PICUs actually for many, many years. But Precedex or Dexmedetomidine is beginning to be introduced in a lot more NICUs. Now this medication is pretty interesting because it actually has an analgesic effect, meaning it actually helps calming down the pain receptors, but it also helps with sedation. Now, remember I told you can't actually calm down the pain receptors and be a sedative? This is one of the few ones that actually can. It actually works on both sides. So it's actually pretty neat, and it's beginning to get favors in the NICU because of that. One thing we have to be really careful though is that it actually does cause some pretty good respiratory depression, and therefore you have to really watch out with making sure that the patient has good respiratory effort when you're starting out, and most of the time it's usually started with patients that have some type of respiratory device, and most commonly they are intubated, meaning they have some type of a plastic tube, they have some type of respiratory tube, they are intubated essentially, okay? Not necessarily, but we see that most commonly when they're receiving a Precedex, okay? So, but this is a good medication. It really does help with both sides, the analgesic effect and the sedative effect. So this is beginning to get more favors in use. Okay, so hopefully this answers your question. Babies do feel pain. Please, please, please do not let anybody tell you, when they say don't start this because that baby is not going to feel any pain. That's a lie, okay? Babies do feel pain, so please, please give them something so they don't feel this pain, okay? They feel it just like us. And not only that, but there's actually data showing that they remember this too. Babies that have been in the NICU will actually have memory when they actually go back in the future. Not back to the future, well, you know what I mean. When they go into the hospital, because unfortunately preemie babies are more prone to be hospitalized in the future. I hate to say it if they have respiratory disease, but when they go and be admitted in the future, they are more prone to be sensitive to IV sticks and other stuff. They feel pain a little bit more than other babies do. They remember this, they have the trauma. So let's be gentle. Let's remember they do feel pain. Let's really try and do our best not to stick for labs that we don't need to, not to have them tolerate pain that they don't need to feel, okay? So please, please share this, okay? I want everybody to know that babies feel pain, so they don't have to get necessary labs they don't really need to and be feeling any pain they don't really need to. Thank you for that question. Really loved it. As always, please, 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 in the comments section, if you have other questions for the NICU doc, go ahead and add them here so then I can look through them, pick one out. Hopefully your question will be next. And if you like these kinds of videos, please like, and if you haven't done so already, subscribe to my channel. And really love reading all the comments, all the likes. Thank you so much, and we'll see you in the next video. Have a good day. Precedex or Dexmedetomidine, Precedex or Precedex or take 273.